Welcome to the podcast. I'm your host, Jim Jorgenson. And on today's show, I'm happy to welcome back Visante 340B expert, Kristin Fox Smith, and Ted Slafsky, publisher and CEO of the 340B Report. You know, Ted's been on the podcast several times, but just in case we have listeners who don't know him, he's had a really fascinating career beginning as a journalist at U.S. News and World Report before he transitioned into a longtime advocate, innovator, and champion role for the 340B program, leading the trade group 340B Health. You know, he's now back in journalism and serves as publisher and CEO of 340B Report, a must-read news service covering all aspects of the 340B program. So welcome, Ted and Kristin.
Thank you.
Thank you so much, Jim. Appreciate it. Good to see you again.
As always.
You, Kristin.
You too.
You know, there's a curse purported to be of Chinese origin that says, "May you live in interesting times." Well, when it comes to the 340B program, we are most certainly experiencing some interesting times. So let's jump right into this discussion. And let's start with the political landscape. You know, GOP leadership of key committees in the Senate and House with responsibility for 340B are now in place, with Senator Cassidy, a physician from Louisiana, chairing the Health Committee in the Senate, and Representative Brett Guthrie from Kentucky chairing the House Energy and Commerce Committee, and Representative Buddy Carter, a pharmacist from Georgia, chairing the Energy and Commerce Health Subcommittee. To date, none of these individuals, particularly Senator Cassidy and Representative Carter, have really been perceived as supporters of the current 340B program. And while it's still early days, you know, what are you seeing so far regarding congressional activity?
Well, that's a good point, Jim. I mean, we do have some new leaders in charge of the committees of jurisdiction over the 340B program. And you are correct that those lawmakers have not been particularly fond of the program, particularly hospital use of the program, as well as concerns over contract pharmacy growth and the growth of the program. But so far there has been little activity on 340B at the federal level, and that's largely having to do with the fact that there's a real focus on getting a big budget bill done that would extend the Trump tax cuts that were enacted in his first administration. And that's going to result, unfortunately, in likelihood of very significant cuts to the Medicaid program, which is something that the providers in the 340B program really rely on, along with the 340B program, to continue their mission. So it's going to be a rough ride ahead in the coming months. But I do think that we will get more attention to 340B soon enough here in Washington, but most of the action so far has been at the state level.
Ted, with so many districts having hospitals that rely on 340B to help keep them open, the program has always enjoyed bipartisan support. Do you think there's any great risk of legislative action that would be seriously detrimental to programs like 340B Access, the bill that Pharma and the National Association of Community Health Centers endorsed last year?
Hopefully not. There certainly is going to be a renewed effort among those who have concerns with 340B to make some fairly drastic changes. The bill that the subcommittee chairman Buddy Carter introduced last year would have been really devastating to the hospitals in the program, resulting in the American Hospital Association predicted 75% of the hospitals in the program losing their eligibility in 340B. It basically would change the program dramatically and limit most hospitals from being able to bring in any revenue or savings from the program, which really would have undermined the very mission of 340B, which is to bring in some revenue to cover the cost of expanding access to care and stretching scarce federal dollars. So it fortunately did not get a lot of traction, but with Mr. Carter being in such an important position, running the health subcommittee, which has the day-to-day jurisdiction over 340B in the House, and Senator Cassidy in the Senate. That's going to be a real challenge. On the positive side, we have folks like Majority Leader Senator John Thune, who's been a great friend to the 340B community. He is now the leader of the U.S. Senate and a very influential Republican lawmaker. And hopefully that will help balance things out.
The bipartisan group of 6 U.S. Senators behind long-awaited 340B program overhaul legislation known as the Sustain 340B Act is continuing its work in the 119th Congress, but with 3 new members. Senators Jerry Moran, Republican Kansas, Shelley Moore Capito, Republican West Virginia, and Tammy Baldwin, Democrat Wisconsin, just announced Senators Mark Wayne Mullen, Republican Oklahoma, John Hickenlooper, Democrat Colorado, and Tim Kaine, Democrat Virginia, as the newest members of the Senate 340B bipartisan working group, which was formed to ensure the program achieves its goal of supporting hospitals and other safety net providers who do serve vulnerable populations. And they replace Senator John Thune. You just mentioned he is now serving as the Senate Majority Leader, and retired Senators Debbie Stabenow, Democrat Michigan, and Ben Cardin, Democrat Maryland. Any thoughts on the work of this group, Ted?
Yeah, that's going to be a really important group of 6 senators, because it really is the only bipartisan initiative going on when it comes to the 340B program. There are different bills that have been introduced and will likely be introduced again. One of them, which was called the 340B Patients Act, would just simply require the drug companies to restore access to 340B pricing in the contract pharmacy setting. That was introduced by Doris Matsui, a Democrat from California, in the House, and Peter Welch, a Democrat from Vermont, in the Senate. They were not able to gain a bipartisan co-sponsor last year. Whether that changes this year will be really important. It will be tremendously helpful if they are able to get a Republican on board. The Sustain 340B Act, which you mentioned, Jim, Senator Thune was actually leading that effort in his role as the Republican whip, which is sort of the number 2 Republican in the Senate in the last session of Congress. But now, as you mentioned, he's very, very busy running the entire U.S. Senate and trying to do all the things that a majority leader has to do on a day-to-day basis. But there are some really good lawmakers on that group of 6, including Senator Mullen from Oklahoma. He's very close with Senator Thune and was one of the first senators to endorse Senator Thune, and he helped round up votes for him in the majority leader race. So I think that you could be rest assured that legislation, assuming it does get finalized, will be one that will be largely positive to the provider community. There certainly will be some areas that the providers will raise concerns over, but I think generally it will be a good bill. And then we have that third bill, which we talked briefly about, the 340B Access Act, which was that bill that was basically a bill that both pharma, the big trade group for the drug industry, and NAC endorsed last year, which we discussed, which would be highly problematic. I'm not sure if NAC is going to be, once again, working with pharma on legislation. I think they felt burned by it, with a lot of efforts at the state level getting stalled, largely due to the federal legislation that they had endorsed would have prevented state laws from being enacted and continued. So it'll be unclear where NAC is going to be this year, but that's the $64,000 question for those old enough to think that $64,000 was a lot of money.
With Robert F. Kennedy Jr., now the head of Health and Human Services, I think his stance on 340B is still unclear. But it was interesting in his confirmation hearings that pharma took a neutral position, and they didn't lobby against him. And his communications director during his hearings and subsequent transition was the chairperson of a political action committee with multiple links to a conservative dark money group that did run a controversial series of ads trying to link 340B to immigration growth and other hot button political and social issues. But I think the big news at HHS relative to HRSA and 340B is their reorganization. You know, HHS is merging HRSA with 4 smaller agencies under a new entity called the Administration for a Healthy America, AHA. And HHS said AHA will improve coordination of health resources for low-income Americans and will focus on areas including primary care, maternal and child health, mental health, environmental health, HIV/AIDS, and workforce development. The other 4 agencies under AHA will be the Substance Abuse and Mental Health Services Administration, the Agency for Toxic Substances and Disease Registry, the National Institute of Occupational Safety and Health, and the Office of the Assistant Secretary for Health. You know, there's also some rumors that the 340B program might be shifted over to the Centers for Medicare and Medicaid Services rather than under HRSA. So a lot going on here. What are you watching there, Ted?
Yeah, I mean, you rightly point out, Jim, that we don't know where RFK Jr. stands on 340B. I don't think it's an area that he has had to really pay any attention to until this current job. And, he's an environmental lawyer. So I think that it's going to be very interesting to see where he ends up, what type of position he takes on the program. I will say that fortunately, so far, the Trump administration is continuing the stance, the long-term stance that has been through many administrations when it comes to opposition to approval of a rebate model, which would be a drastic change to the 340B program. But, the pharmaceutical industry is very powerful and has great connections to both sides of the aisle. So it is unclear to me where we will go there. As for the possibility of the 340B program being removed from HRSA and going under CMS jurisdiction, I would say that most providers are pretty worried about that. They're concerned because CMS has had sort of a tradition of proposals, and some that have actually been enacted that have really harmed 340B providers. That includes the dramatic Medicare Part B cuts in the first Trump administration that were eventually overturned by the U.S. Supreme Court in a 9-0 decision. And then we also have Medicaid pharmacy reimbursement cuts and other changes that have occurred that have been harmful to the 340B provider community. I think despite some reservations that the 340B providers have had with HRSA, I think they feel more confident and more comfortable working with HRSA. So it shall be really interesting to see what happens there.
Yeah, and of course we've now had a leadership change at CMS as well, with Dr. Oz being confirmed. Any thoughts on where he might stand on 340B?
That's another one that's a good question. My publication, 340B Report, actually broke some news earlier this year that Dr. Oz's family, including Dr. Oz and his son, were investors and actually involved in a company that wants to provide services to 340B hospitals in the employer-sponsored healthcare area. It is unclear where Dr. Oz stands on 340B. His son certainly said that it's an underutilized program and one that he finds fascinating. So we shall see whether Dr. Oz shares his son's feelings about the program. But I certainly know that the drug industry will be lobbying Dr. Oz very aggressively, and they have a way of influencing key lawmakers and key administrators.
Elon Musk and Doge have been in the spotlight a lot. And, while there haven't been any direct actions on 340B, Doge moves could ultimately impact 340B. The Office of Pharmacy Affairs has always operated on a very thin budget with limited personnel resources. So what might the impact of some of these Doge firings have on OPA and the 340B program?
The folks at HHS, as Jim and Kristin, are really, really upset right now. It's a very, very difficult time to be working in the federal government. A lot of their good friends and colleagues have been fired, and more are likely to be let go in the coming months. The morale, I would say, is at an all-time low. As for 340B and DOJ, that's a good question. As you mentioned, there is a key advisor who worked for RFK Jr. during his confirmation hearing, who has a very close relationship with Elon Musk, and maybe saying some things about 340B, which may not be fair or accurate. So it's unclear, but hopefully the Office of Pharmacy Affairs will not be gutted, because, as you know, it's already a very, very small department. And my understanding is that those who are located outside of Washington in remote jobs are losing their jobs, particularly those where there is no home office in places like Boston. So there's a real concern there. Kristin, have you heard some of that information?
I've heard a lot of concerns about what's going to happen with audits and oversight, just given that it feels like the last several years have continued to get smaller on the audit front, even though we're still seeing the same number of audits being pushed through as it relates to final reports and findings and corrective action plans. But the level of monitoring and oversight has been much less. So when we look back and continue to support covered entities that are going through HRSA audits, the level of thoroughness and the level of really looking under the hood, I would say, is less than a third of what it used to be in terms of what's being looked at. They are still looking at the same systems, but not with the same set of eyes. And so I don't know if it's they have less time to spend, or there's less they're really in a position to enforce. But it's unfortunate because covered entities are spending a lot of time managing aspects of the 340B program that they're not able to demonstrate their compliance for when they receive an external audit. And the items that we are finding that covered entities have problems or gaps with are the minutia, but the minutia is enough to still result in a finding and then potentially a corrective action plan and repayment. So it'll be interesting to see if audits return to the thoroughness that they were even 3 years ago, or that if audits increase, and also if those extend to manufacturers as well. We have many covered entities working on administrative dispute resolutions right now with no clear path. And we've got some bad players in the manufacturer space that are just refusing to honor pricing and not living up to their end of the bargain. And so I hope that we still have resources in place to be able to prevent that and to manage that to the extent possible.
Interesting.
So conservative outlets continue to advocate for DOJ to look at the 340B program as a money-saving opportunity, but they continue to miss the boat in that 340B dollars are not federal money, it's pharma money. It's unclear if this is ignorance, if it's intentional or some type of calculated strategy, but do you have any ideas as to what can be done to better educate people about the narrative of where this money is coming from?
Oh, yeah, you're right. I mean, when you look at, and I look at all the stories because that is my job as the publisher and CEO of 340B Report. Every article that goes through the transom arrives in my inbox, and most of them have been talking about how the 340B program is hurting taxpayers and hurting patients and all things which are just untrue. Unfortunately, the other side has a lot more money than the providers in the program. But I think what the providers need to be doing is, basically a few things. One of them is to regularly talk and meet with their federal lawmakers, their state lawmakers, and the media at home and nationally if they have the opportunity. Because they're going to out op-ed you 8-1, but if you can make it 8-2, that's a win, So I think it's really important to be very engaged at the state, local, and national level.
Kristin, Ted mentioned Medicaid cuts, and I concur. I think it's likely we're going to see cuts in Medicaid and a shift in funding support back to the states with subsequent loss of Medicaid coverage for significant numbers of patients. If that happens, it may result in hospitals that are close to the DSH adjustment percentage threshold for program eligibility no longer being eligible. So, what should hospitals be preparing for around Medicaid and eligibility?
Where we're really seeing changes is covered entities approaching mental health patients and labor and delivery and moms and OB services in general in a different way. Although a lot of the medications and the management and maintenance of mental health patients aren't very lucrative or financially valuable in terms of retail prescriptions or those take-home scripts, they really do help in terms of number of Medicaid days and opportunities to increase uncompensated care. We continue to have so many covered entities that are just on the verge of being eligible or not being eligible. And the concern is how many covered entities this would hurt and the patients downstream in the event that we see any significant shifts, because it's already too few covered entities. I mean, we already don't have the number of covered entities in the space that we need to be able to cover the patients that are currently looking for care, and not just pharmacy care, but medical care and dental care and all of the services that come along with a lot of our FQHCs and community health centers. So I think the more we can do to be able to identify services like psych and labor and delivery that help with increasing the number of days that hospitals are able to claim on cost reports, the better chance we have of increasing those DSH percentages.
It seems likely that the Trump administration is going to keep Medicare intact, but really focus on shifting to Medicare Advantage. Any 340B program concerns around this potential shift?
I think it's too soon to know how a change to Medicare Advantage would impact what we're seeing. We still have a lot of Medicare Advantage plans that include prescription coverage and those that don't. So in terms of outpatient prescription access or availability for retail medications, it's really unknown. But in terms of just overall providing care and whether or not there's any offset of what we're seeing for Medicaid days or Medicaid coverage, I think it's too early to tell, but there's definitely ways that it could tip the boat in both directions, depending on what those Medicare Advantage changes might be.
The last Trump administration spent a lot of effort on repealing and replacing the Affordable Care Act. And this time around, that doesn't seem to be a strategy that they're going to pursue. But I do think it's likely that they'll let the current ACA subsidies expire in December, and which would result in increased premiums and out-of-pocket costs for really millions of current ACA enrollees, which could make an exchange plan unaffordable with a resultant increase in the number of uninsured. That sounds bad, but ultimately this could help DSH adjustment percentage calculations for programs at risk of losing eligibility. But do you think this will actually be material enough for them?
It could be. I mean, it depends on the size of the shift and the number of individuals. We've talked to several state Medicaid programs that are still talking about reductions in overall offerings for care. We have multiple covered entities that are looking at managing or decreasing staff or outsourcing services where necessary to be able to put in place some sort of revised attempt to manage compliance and internal audit needs as it relates to Medicaid patient population, which, given the concerns around duplicate discounts, a lot of 340B programs resources are tied up in making sure that we avoid those duplicate discounts. So as Medicaid percentages or numbers go down, I think we could look at a reasonable reduction of resources needed to support the 340B program for any given covered entity. But the problem is whether or not it's material enough to change eligibility for any covered entity or allow them to come back into the program if they're a covered entity that was on the verge before, and we have many of those. I think it's just there's too much that's unknown right now.
There's also been some discussion around the nonprofit status of organizations. Moves to create stricter charity care and community benefit requirements could impact 340B eligibility for some clients if numbers of indigent patients were reduced, or if new 340B eligibility standards are introduced that look at the percentage of total uncompensated care as opposed to current DSH adjustment percentage. Any concerns there?
No, I mean, what I think is good is that most covered entities have really ramped up the time and effort they spend in detailing the uncompensated care and the services they are able to provide in preparation for an audit, and that process is ongoing. So I think the benefit of this is, in the event that we needed to provide more clarity in regards to what a community benefit gives back or how charity care is being used, I think we have the necessary information to be able to respond to this positively. It's just hard to know whether or not that data would be used in any granularity, or if it will just be very surface like it is right now. So right now we're recommending that covered entities provide an overview of how these dollars are used and how savings is implemented, but we're not really asking them to provide all of the detail underneath that. It may come to a point in time where they're going to have to, and that will partially be in defense of the services that they're providing if there's going to be a look at moving the DSH adjustment percentage. So I think good information there just in regards to covered entities are now better able to quantify and materialize the services that fall under this area, and they have a lot more granular detail available in the event that it needed to be provided.
Ted, shifting to the judiciary front, we still have a number of active suits pending final resolution. What's the current status in this area?
Yeah, well, you're right. There are so many lawsuits right now that's hard to keep up with it, Jim. Just in today's issue, we reported on AbbVie suing the three new states that have just enacted contract pharmacy protection laws, and that won't be the last lawsuit. We have 13 states that have enacted contract pharmacy protection laws, and in about 12 of them so far, there have been lawsuits against those states, basically trying to block implementation of the state contract pharmacy protection laws. Most of the decisions have been largely positive for the states, and with the Arkansas law being the one that has moved the furthest along because it was the first law in the nation to address the contract pharmacy issue. And that has been basically has been blessed by both the federal district court and the federal appeals court in a 3-0 decision at the appellate level. And the Supreme Court refused to take up pharma's request to challenge it. So that is promising. There are other states that are moving along in a positive way with some good decisions so far, but a few setbacks as well, including in the state of West Virginia, as well as a few state contract pharmacy laws that were determined to be unenforceable because the law was not written well without any enforcement mechanism. But overall, I'd say there's been mostly positive results on the state contract pharmacy laws. As for the other laws that are being challenged, or other types of decisions that are being challenged, HRSA was sued by a number of drug companies over proposed rebate models. Basically, the drug industry would like to change 340B from an upfront discount program, which is the way the program has worked for over 30 years, to a rebate model where the providers would have to purchase the drugs at a much higher price and then hope that the drug industry provides a rebate after they approve the claim. This has caused a tremendous amount of anxiety among providers, as well as bipartisan members of Congress, and even HRSA, both the Biden and Trump administration, have stood in support of the longstanding belief that decisions about whether you can agree to a rebate model have to be approved by the HHS secretary. And that's we have one limited rebate model, and that's for certain ADAP programs, and that is the only exception to the upfront discount program. And that's something where it really wasn't feasible for the ADAPs to do it through an upfront discount. So there are many lawsuits. That's another thing that we're doing here at 340B Report, is tracking all the litigation that's going on. It's really the Full Employment Act for attorneys throughout the nation.
Let me throw one last topic out there for you guys. It appears that discussions are continuing to escalate around tariffs on pharmaceutical imports. What do you think the downstream effect of that might be if those are implemented on the 340B program?
Do you want to start, Kristin, or how do you want to do that?
You can start.
Okay. Well, it's funny. We're writing a story about that on Thursday, and I have not had a chance to review the article yet. But I will tell you that I think there's certainly concern about tariffs, because tariffs are a tax, and when the price of a drug goes up, this will have an impact throughout the pipeline and throughout the supply chain. And this isn't just on brand name drugs. It could be on generic drugs, which are very cost sensitive. And suddenly, if your generic drug costs twice as much as it used to, it starts to add up. So there's certainly a lot of concern among all stakeholders. This is one where I think the providers and the drug industry agree. Tariffs are not a good idea. Now, I can understand why President Trump would like to bring some of this manufacturing back here at home, but I don't know if it's realistic to suddenly start building tons of plants here in the U.S., particularly the generic makers. They can't afford to do it. So that's the challenge.
Yeah, and I think the other issue is, even if you do build the plants, oftentimes the active pharmaceutical ingredient isn't produced here, so you still have to import that.
That's right, and that would take years to resolve. It's certainly not anything that could be done overnight, and in the meantime, the tariffs would be a problem. Perhaps there's another way to do it, through tax incentives in other ways that are less focused on penalty and more on trying to incentivize manufacturers to invest in the United States. I think that might be the way to go.
Right. And in terms of operationalizing that, it's just too many changes that are happening too quickly. Every wholesaler and GPO is sending out notifications to their covered entities and clients saying they don't yet have an accurate depiction of what tariffs in the drug space may mean in terms of pricing or access, because that's another concern, is not just price, but also access, and just making sure that covered entities know that they're monitoring to the extent possible. And as soon as they have more information or updates that are time sensitive, that they'll provide them. But I think, to your point, Ted, the reality of having plants move quickly enough to impact the pipeline and all of the supply chain pieces that are needed to effectively meet our patients' drug needs on a day-to-day basis, there's no time. There's no time to add something so heavy that covered entities move away from all brand name medications, honestly, and look to lower cost, or even we look at a lot of the outsourced and compounded products that have questions around integrity of drug and some of the things that are happening in that space to avoid paying the real price for the cost of pure ingredients. It's concerning that covered entities will go a different direction and try to obtain drugs. So hopefully we get more information about what that's going to look like and how it really will impact ability to access medications.
And hopefully cooler heads will prevail.
Definitely.
Well, great information, you two, as always. Any last thoughts before we close?
I would just say that be involved, both at everything from your local mayor to your state reps, and of course your federal delegation is going to be important, particularly with the changes coming down the pike, both with the Medicaid program and potentially the 340B program.
And I'd say we gauge what is important and what has impact for our covered entities based on information that Ted releases super timely in regards to the 340B report, because that determines, like, do we have covered entities that have a risk level with whatever this update is, or is it more informational and information that we can pass along to our clients that don't currently have a publication subscription? It's interesting as Ted over time has released information about what states have what laws. I can't tell you how many times specific states have reached out that don't have any legislation moving and asked us, how do we get involved? Yesterday, I think I talked to 4 or 5 Washington state hospitals and different covered entities that said, we've really had no legislation pending. Nothing's happening at the state level. How can we get involved? And so I think having that be top of mind in terms of advocacy and continuing to pay attention to changes that will benefit hospitals and everybody, all covered entities that trickle down from there, is critical. And having access to timely information has allowed us to help in those conversations with our covered entities. So Ted, thank you for producing something that I think has a lot of value, and it has a lot of value to a lot of different stakeholders in the 340B program.
Well, thank you for the nice shout out on 340B report. I really appreciate it. It's a labor of love for me. You know, my career began in journalism, as Jim mentioned, and I'm now back in journalism after years of advocacy, and I'm really enjoying the job. And, Visante has been a longtime sponsor of 340B report. And I do want to point out that those who are listening to this interview or podcast can use a special discount code called Visante25 to get a 25% discount on their subscription to 340B report if you are a first-time subscriber. The website is 340breport.com. And you guys have been so helpful to us. The articles you write are really appreciated by our readership, and the guidance that particularly you provide, Kristin, to our reporters has been invaluable as we continue down this 340B journey.
Thank you. And I would say one last piece of information I think is helpful is, prior to the last several years of having access to really good information that was material, a lot of our steering committees that we support didn't ever have time or a placeholder for legislative updates or legislative activity. And given now that this information is accessible and that they can become members and don't have to dig to be able to find information, a lot of our steering committees now have a 15-minute session where they just focus on legislative activity. And I can't tell you how often the documents that they're referring to are coming from your publication. So I definitely think it's important, it matters. And I think for covered entities that really want to be up to date and want to make sure that they're doing everything they can to strengthen the program, they're readers. So I think that's really important.
Well, that means a lot. Thank you. And I appreciate it. It's really been a lot of fun running 340B report. It's a lot of work. As you know, there are more breaking news stories than we ever expected. You get a lot more emails than twice a week. Originally it was supposed to be a newsletter that just comes out twice a week, but we have so many news alerts that we're keeping the staff quite busy, but it's very stimulating.
Well, thanks both of you for being on the podcast today, and thanks everybody for listening.